Hi guys. I'm just going to let a few more people join and then we can go ahead. Okay, so I'm going to just start ahead. My name's Sara. I'm an F1 doctor, and I'm going to be presenting to you guys and teaching you a little bit about breast conditions and breast surgery. So thanks everyone for coming, and I've got one of my other colleagues, Daniel, who's moderating as well. So hopefully this will be useful for you guys. So just to go over our learning outcomes for today, I'm just going to go over some common breast-related presentations and conditions, and we can go over the management and investigations for these, especially tailored for your UKMLA exams and finals. And then we'll apply our learning with some SBA questions. And then I just wanted to highlight at the end, for anyone who's interested, sort of how getting into a career in breast surgery works and possible training pathways. So let's go. So just some differentials for breast pain and tenderness. Common ones are cyclical changes with periods, monthly. Ladies can complain of pain and tenderness around their hormonal cycle changes at pregnancy, mastitis. There could be malignancy or metastasis, abscess, and certain cysts as well. So we'll cover these kind of things. Right. So in terms of presentations related to breasts, there can be pain and tenderness. There can be a breast lump or nipple changes or skin changes. And then obviously we have galactorrhea, where there's milky discharge, and gynecomastia, which I'm not really going to touch over today because that's more of an endocrinology sort of issue. But it's definitely a presentation. And then obviously there's the systemic symptoms that come with all these presentations. And then those are the lists of conditions that we'll go over. Obviously there's a lot more conditions that we could cover, but for the UKMLA exam, I've just gone over what they've mentioned in the content map and what comes more commonly, so you guys are more prepared for that. So just a little bit about breast anatomy. I'm just going to do a summary. I'm sure we all know a thing or two about it. So we have the mammary glands, as you can see, and these are basically modified sweat glands, and they are made up of a series of ducts and secretory lobules. And each of those lobules within the glands have a lot of alveoli that are drained by a single lactiferous duct. And then the ducts converge at the nipple, essentially, as you can see in the photo. And then you've got connective tissue stroma, which sort of supports the mammary structures and the glands, and you've got the fibrous and fatty components to it as well. There's the ligament of Cooper, which is a suspensory ligament that sort of is around the breast tissue and helps to support those structures. And then you've got the pectoral fascia, where the base of the breast lies as well. So that's just a little bit about the anatomy. There is a potential space, there's a space called the retromammary space, where you've got the loose connective tissue between the breast and the pectoral fascia, and that's often used in plastic surgery or reconstructive surgery, especially with implants and things like that. So that's just a little piece of information. And then just to quickly go over anatomy again with the vasculature and things like that. The arterial supply to the medial aspect of the breast is through the internal thoracic artery, which is a branch of the subclavian artery. And then the lateral part of the breast receives blood from 4 different vessels, but I'm not going to bore everyone with all of those things. And then the veins correspond with the arteries, and they all drain into the axillary and internal thoracic veins. In terms of innervation, there's the anterior and lateral subcutaneous branches of the intercostal nerves, and the nerves they provide sensory and autonomic nerve fibers. And then finally, we've got the milk production and secretion, which is regulated by hormones. So it's not to do with the nerves. The nerve structures are just there for sensory and autonomic functions, and the hormones are what really drive the milk production and secretion. In terms of lymphatics, obviously the lymphatics have a very great importance when it comes to metastasis of brain cancer cells. There's 3 different groups of lymph nodes that receive the lymph from breast tissue. The axillary node, which receives about 75% of the lymph from the breast tissue, and then we've got the parasternal nodes, which receive 20%, and then the posterior intercostal nodes, which receive about 5%. So that's of clinical importance with the nodes. And then going on then, so I've kind of tried to break it up into subgroups of conditions, and we'll start with the inflammatory ones first. So mastitis, definition of it is just inflammation of breast tissue, and then you can have infection or it can be without infection. it is a common complication of breastfeeding. So you tend to see it quite commonly in women, obviously, who are breastfeeding. There can be different causes. So obstruction is one of them. So you can have obstruction in the ducts, which causes accumulation of milk and then leading to inflammation, possibly infection. It could be a reaction to foreign bodies, such as piercings, implants, and things like that, or there can be a route for bacteria to enter through the nipple, going into the ducts, and then causing infection, which then leads to mastitis. There's different organisms that can be implicated in mastitis with infection, but the most common organism, and one that's asked about in exams, is Staph aureus. So that's one thing for you guys to be aware of. In terms of the presentation, it's usually unilateral breast pain, it's tender, and as you can see in that photo, it can be erythematous, can feel warm, and the breast can feel inflamed as well. There can be nipple discharge, but you can have presentations of mastitis without. And of course, if there is an associated infection, then patients can be quite unwell, or they can have fevers and systemic symptoms as well. So yeah, and then moving on to management, it just kind of, you can sort of classify it depending on what is the cause. So if there's an obstruction, we try and obstruction and there's no infection, that is, you can go with conservative management. So it's really important to make sure that you advise women to continue breastfeeding. It can be quite painful and uncomfortable for them, but it's very important to give that advice that they can continue breastfeeding, and they should do, to sort of express milk. And they can also have breast massages that can help with the flow as well, especially in obstruction. You can provide them with heat packs, or advise for them to have warm showers, and obviously give them analgesia just to manage their pain if there's no associated infection. If there is infection and they have infective symptoms, flucloxacillin is the first line antibiotic. Obviously, if they're pen allergic, then that you would go with erythromycin in that case. And then if you're in hospital and you're able to, then, or even in GP, then you can send off the milk sample for culture and sensitivities, which can direct further antibiotic therapy if it does grow any bugs that are sensitive to other antibiotics. If you're suspecting a candidal infection, then fluconazole is the form of treatment for that. And again, as I said, just make sure that you encourage them to continue breastfeeding. If mastitis isn't treated, especially when there's an associated infection, there is a risk of a breast abscess. So that's really important to make patients be aware of when you see them, and you treat them with antibiotics. It's good to safety net them and let them know of the signs and symptoms of breast abscesses, which we'll go on to, so that they know to come back. And the sort of management is obviously very different for breast abscesses. Okay, so going on next then to breast abscesses. So a breast abscess is essentially a collection of pus within the area of the breast, and usually caused by bacteria. There are actually some risk factors for breast abscesses. Smoking, if there's damage to the nipple, especially if patients have eczema, or, as I said, foreign bodies and things like that, or if they have underlying breast disease that affects drainage and can cause obstruction. Obviously, if there's cancer or as I said, the foreign bodies, they can cause obstruction and things like that. So that's good to be aware of. In terms of the presentation with breast abscesses, you get a swollen, fluctuant and tender lump. It's really important to, I want to highlight the word fluctuant there. So that gives it a sort of a big giveaway that it's a breast abscess rather than maybe a lump. And by fluctuance, I mean you're able to move around the fluid within the lump. When you put pressure on the breast and you're doing your breast examination, you can clearly tell that there's fluid inside that collection, and it can be moved around. And as I said, swollen and tender. And then you can have other symptoms such as muscle ache, especially around the area. They can be quite fatigued, tired, and signs of sepsis if they present quite unwell. It's really important, especially in a GP setting, or if you're not in a hospital and you encounter these patients, they do need urgent general surgery referral, where they'll go into hospital and they'll often get an ultrasound just to confirm there's an abscess. But if there's enough clinical indication that it's not, then they might just use the ultrasound, use a needle aspiration, and then or surgically drain that abscess, because it's really important to try and relieve the abscess and get it taken out as soon as possible. And then, as I said, just like with mastitis, you can, with infection, you can send the culture that you obtain during the drainage for culture and sensitivities to direct antibiotics further. Usually when patients go to hospital with breast abscesses, they do receive IV antibiotics, but I guess clinical judgment can be used to decide if oral can be used instead of IV. And we usually give antibiotics for about 7 to 10 days just to make sure everything's cleared and the patient's okay. And then moving on. So it's just for anyone who's interested, really, that's what that picture on the top is, what a breast abscess can look like. And as you can see, it sort of looks like it would be fluctuant. It's reflecting light back. So that's sort of what an abscess would look like under the breast skin. And then on an ultrasound scan, the features of a breast abscess obviously have, as I've mentioned there, it's a very well circumscribed border, so there's no irregularities around the border, and there's vascularity around it, and you can see the echoes within it. So as you can see within that image that you can see there, there's within the cavity, there's different sort of grades of the color is quite different, so it's echoing back different frequencies, and that's what an abscess looks on ultrasound. And then there's a mammogram finding of it as well. Okay. If anyone has any questions, feel free to put them in the chat, or if I'm going too slow or too fast, just pop it in the chat and we can do it however best suits people. Okay, so I'll go on to the next one then. Next is breast cysts. So usually they can just be one, but some patients can end up having multiple, and these are benign. It's really important to make sure that we reassure patients when we do have these presentations that they are benign, because patients can freak out and think the worst in these scenarios. They're fluid-filled sacs as well, so again, they can feel fluctuant rather than hard and like a proper breast lump. As I said, they're usually individual lumps, but there can be multiple. They are the most common cause of breast lumps for patients coming in and complaining of breast lumps. They usually occur in women about 30 to 50 years old. They can be painful, and sometimes they fluctuate over the patient's menstrual cycle. So if a patient comes in, says, they have what feels like a fluid-filled sac that can get bigger or smaller throughout the month, correlating with their menstrual cycle, then that's a big hint that it could be a breast cyst. When you do your breast examination, it will feel smooth. The borders will feel round. There won't be any irregularities usually. It's mobile, so you can actually move the cyst around. It doesn't feel like it's fixed under the skin to the tissue. And as I said, because it's fluid filled, it will feel fluctuant. Of course, as I mentioned, you have to do an examination and make sure you're ruling out any red flag signs and symptoms before deciding that it's a breast cyst. Patients are often referred to breast clinic, where they'll use an ultrasound scan or mammogram to definitively diagnose it. If there's suspicion that it might be a breast cyst, but there's also a risk or worry that it could be something else, then they can have further investigations with aspiration to provide us with a definitive diagnosis. Or sometimes they can be quite painful, or if they're big enough and are causing discomfort, then we can aspirate them for therapeutic effect. But as I said, in these scenarios, reassurance is a really big part, because it can be quite worrying to find what feels like a breast lump and think the worst with cancer. So it's really important to reassure your patients and let them know that a breast cyst itself doesn't increase the risk of breast cancer. They're not harmful or dangerous, even though they feel painful or uncomfortable for them. but of course make them breast aware as always that, you know, they might have a breast cyst, but if anything changes with the breast cyst, if it starts to suddenly get really big, or it's not fluctuant anymore and it's hard, or any other concerning symptoms, then they should always come back and rediscuss if things change. So that's really important with breast cysts. And I've got a photo of a breast cyst up there as well on ultrasound, so that's how it looks like up there. And then patients can have fibrocystic breasts, where essentially it's like a lumpy breast where you've got pain and tenderness that also fluctuates with the menstrual cycle. Patients will end up having fluid-filled sacs as well as fibrous sacs. So you can have a mixture of sacs that feel fluid-filled and fluctuate, and some that feel a bit harder. And that's the pathophysiology behind this, is that with the breast tissue responding to estrogen and progesterone, sometimes they can become fibrous, or they can become cystic, and then patients will end up getting multiple of these cysts and fibrous-filled sacs that cause them to have a lumpy breast. And again, these fluctuate with the menstrual cycle. They can get bigger or smaller with the patient's cycle. It can be unilateral or bilateral. Again, it's very important to use your breast examination to feel both breasts, see how these sacs feel, how many there are, and gain a good history of if it varies with their menstrual cycle and any other concerning features. They can feel tender or uncomfortable as well. Again, with just like the cyst, the patients are referred to breast clinic just to ensure that we've excluded a malignancy. You can get them to wear supportive bras or give them painkillers if it is becoming uncomfortable enough, and heat packs are also very useful to manage. If it's a very extreme scenario and patients are in a lot of pain or it's causing a lot of issues and discomfort, then you can refer to breast consultants or clinics where they might consider hormonal treatments that will help with the symptoms that they're getting. So it's good to be aware of that, because sometimes, even though they are still benign, patients can actually be in a lot of pain and discomfort. So there's more than just reassurance and painkillers available in this scenario. Moving on. So we've gone through some of the more common inflammatory conditions in terms of breast presentations. I'm just going to give you guys a couple of minutes just to read over this question, and then I'm going to put a poll in the chat if you guys could just pick the most appropriate option, and then we can talk through it. Okay, just going to give you one more minute and then we can discuss. Okay, cool. So I think a lot of you have responded, which is great. Most people have gone for option 2, which is commence all antibiotics and review in 5 days. And a few of you have actually gone for number 3, which is admit to hospital for IV antibiotics and aspiration. And I think one of you might have gone for the final option, which is reassurance, and that the symptoms should settle. So the correct answer is number 3, which is to admit to hospital for IV antibiotics and aspiration. So I just want to go over the main points of the question and sort of highlight which words would point you towards the right answer. So we know it's a young lady. She's 34 years old. She's had a 4-week history of a painful breast, and it's unilateral on the right side. It's become worse over the last week or so, despite having reached out to her midwife. She's breastfeeding, and she's been having issues with that. And then once you've examined her, you notice she's sweaty and she's febrile, so that's concerning. She's tachycardic, so these are sort of maybe septic looking pictures, or at least she's definitely unwell. And then, as we said, there's a tender, palpable and fluctuant lump. So initially you might think, okay, this could be mastitis, and with mastitis, as we discussed, it could be obstructive without infection, or it could be with infection. Given her sort of picture of being sweaty and febrile, that points us towards infection. And I think the biggest giveaway is the fact that it's tender, it's palpable and fluctuant, and that points us towards a breast abscess rather than mastitis. So she could have had mastitis, which was then untreated and now has developed into a breast abscess in the right lower quadrant. And she's got the other signs and symptoms we talked about, like erythema and edema. And as I said, an abscess is not something that we would just give antibiotics for and review them. It does need to be treated immediately, and they need immediate referral to general surgery in the hospital, where they will give them IV antibiotics usually and aspirate, just to make sure that it doesn't cause any other problems or further complications. So I can see why most of you would have gone with the oral antibiotics option, because initially the presentation sort of could suggest that it's mastitis, but it's really, really important here to the second paragraph really highlights that, one, she's very unwell, so and two, there's an abscess there that needs to be treated as soon as possible. So thank you guys for joining on that. If anyone has any questions and wants to ask them, please put them in the chat now before I move on. Okay. Not seeing any, so I'm just going to move on. Okay, so that's the inflammatory conditions relating to breast surgery covered mostly, or the common ones that you guys will encounter in practice or in exam conditions. Now we'll just go on to the benign breast tumours. So fibroadenoma, it's one of those that you hear about quite often. They're benign tumours of the stroma or epithelial tissue. They are more common in women who are 20 to 40 years old, and they respond to the hormones estrogen and progesterone, which is why post-menopause they tend to get smaller and regress. So the age is something that you can use to sort of classify if someone turns up with a breast lump, and you want to sort of come up with differentials. Then going on to the symptoms, they're usually painless, so they're not like the inflammatory ones that we discussed that were quite painful and tender. These are painless, they're still smooth, they're round, there's no irregularities around the borders, they're firm and they're mobile, so you can move them around. And a lot of people refer to them as breast mouse because of the shape and usually being able to move them around in the breast tissue. But it's important to know here they're firm, so they're not like the breast abscesses or the cysts that we talked about that were fluctuant and you could feel them be fluid filled. These are firm, because obviously they're benign they are tumours. They are benign, but it's very important to gain a good clinical history, and just on examination find out about the lump, because if it's a complex fibroadenoma and the patient has a positive family history of breast cancer, then that might indicate a higher risk, and they'll need further investigations just to rule things out and make sure that it is just a benign fibroadenoma rather than something more sinister. So that photo there is what it looks like in real life once it's been excised. As you can see, it looks firm, it's not filled with fluid, and then the ultrasound up there is what it looks like on ultrasound. Okay, Moving on, then we've got the introductal papillomas. So commonly you get a singular papilloma, but you can have multiple. They're again benign, but these are wart-like tumours and they grow in the milk ducts. They consist of fibrous tissues and blood vessels and gland tissues. So sometimes as we go on into the presentation, they can cause clear or bloody nipple discharge because of those blood vessels that they are made up of. They grow in the large duct. So if you get singular papillomas, they often grow in the large ducts near the nipple, as you can see. And as I said, you can have bloody or clear discharge because of the contents of the actual papilloma. And if it is a singular papilloma, it will usually feel like a small lump just behind or next to the nipple. And then if you have multiple papillomas, then they can be quite further into the breast tissue and less superficial, and they grow in the smaller milk ducts further and further away from the nipple, and so they are less likely to sort of release that discharge, the bloody or clear nipple discharge, because they are so far back. So again, these aren't fluctuant or soft like the other ones that we mentioned initially. So that's what really makes them differ. And with the other presentations we've had so far, we've not had any discharge from the nipple. So the clear or bloody discharge is something that could point you towards introductal papillomas. Going on to the management, then we would just use fine needle aspiration or excision biopsy just to sort of find out exactly what it is and get a definitive diagnosis. And in terms of managing, you can use vacuum assisted excision, where there's a vacuum attached to a needle. You insert it into the breast near the papilloma and it just sucks it out. So that's management for those. Or if they are too big or anything that warrants surgery, then you can surgically excise them as well. But obviously with the vacuum assisted excision, it's a lot more non-invasive and more straightforward to do if possible. So the solitary papillomas don't raise breast cancer risk unless there's other sinister breast changes or family history or any other concerning things in the history. But the multiple papillomas do increase breast cancer. So this is very important to be aware of when you do your breast examinations, to make sure that it's not just one singular lump, and really go and when you're doing the examination, make sure that you're ruling out any other lumps anywhere else, gaining a good history, and sort of finding out about family history, family risk factors, patient risk factors and histories, just because if you have these other sinister aspects of the history, then you'll need to do more investigations and being aware that it could be more sinister. And on the top there, that's what they look like on a mammogram. So as you can see there, this is the ones that are close to the nipple, and they're very close there. That's why you can see the nipple discharges. Okay, then we will go on to lipomas. So lipomas are just tumors, again, benign, of fatty tissue. They can be almost, as you all know, lipomas can be anywhere in the body, so the breast is no different. And obviously there's a lot of fatty tissue in the breast, so they can be quite common in the breast. They're usually common in ladies who are 40 to 60 years old, so going a bit more middle-aged, older ladies rather than younger ones. So that's something to be aware of in terms of presentation. They are just fatty tissue, so they feel quite soft. Again, they're painless, they're mobile, you're able to move them around when you're doing your breast examination, and there's no overlying breast skin changes or any nipple discharge and things like that, because it is really just a lump of fat. And in terms of management, sometimes if you feel confident, obviously as an F1, F2, I mean, I wouldn't feel confident to just examine a breast lump, even knowing how much I do, how much I don't. I wouldn't feel confident to say it's nothing, but when if you're a GP, then sometimes if they've got enough experience and confidence in their examination skills, they can actually be diagnosed in the GP without further investigating. Again, it's really important to reassure patients. If you do have further concerns, and of course always refer the patient to breast clinic where they'll have a full workup, and they'll be reassured there as well. And again, if you are reassuring patients and sending them home, it's really important to highlight they should be breast aware. If there's any other lumps, if there's any changes within the lump, they should always come back and rediscuss, because things can change. If there's any discomfort or for cosmetic reasons or pain, then they can be referred to breast surgeons who'll have consultations and remove them if need be. But again, that's very case dependent, and most people don't get surgery for these things. Okay, and now we'll just go on to a question then. So I'll give you guys a couple of minutes just to read through, and then we can discuss the answer. Okay. Oh, I forgot to release the poll, didn't I? Sorry, guys. I'll just put the poll on a second. Sorry, if you just use this poll for this second question. And thank you to those who put it in the chat. Okay. Yep, so most of you have gone for the final option. I think on the slide I've put it as the wrong one, so ignore that, but it is a fibroadenoma, and the key features here being her age. It's relatively small, is 2 to 3 centimeters in size, and painless, as we discussed. It's mobile, meaning you can move it around. So yeah, if it was, for example, a cyst, then it would feel fluctuant. And cysts can cause tenderness as well, and she doesn't have any sort of features of carcinoma at this stage. So most of you have gone for the right answer, being fibroadenoma. Ignore the second slide. Cool. If you guys want a break, I can give you 5 minutes just to get a coffee, or if you want me to carry on, I can continue. If you just want to put in the chat, whatever works, I'm happy to continue. I just thought a break might be nice after having talked at you for a while. No one's opposing. So if you guys want to resume at 1:45, then we can go through the rest of the slides. There's about 20 left to go through, and hopefully we can just work through them quickly. Okay, cool. So we'll move on to the final part, which is just covering malignant breast tumours. Breast cancer is the most common female malignancy. It accounts for about 30% of new cancer diagnoses in women in the UK. It's quite rare in men. About 1% of men get breast cancer. So that's something to be aware of. It can be overlooked in men. It doesn't mean that it never happens. It's quite rare, but we should always be aware if men come with breast lumps or any issues. It's something to have in the back of your mind, because although it is rare, it does happen. The risk factors, of course, being female is one of the biggest risk factors. Obesity, smoking, increased estrogen exposure. So, for example, having an earlier onset period or a later menopause, a family history, especially if you've had a first-degree relative. The combined oral contraceptive does have a small increase in risk, but once patients stop taking the COCP, then after about 10 years, the risk goes back to being what it is for women who haven't had the COCP, and particularly combined HRT can be a risk factor as well. I wanted to just touch quickly upon metastases, sites of metastases for breast cancer. Liver, lungs, bones, and brain are the most common sites of metastases when patients have brain cancer. So you can remember it as the 2 L's and the 2 B's if that works, but it's something to be aware of. So in terms of genetics, so BRCA, the BRCA gene, I'm sure a lot of you have heard of, is the breast cancer gene. It's a tumor suppressor gene, and there's 2 different types on 2 different chromosomes. Mutations in these genes can increase the risk of breast cancer, as you're all aware. So if you're a carrier, BRCA1 is on chromosome 17, and if you're a carrier of a mutated BRCA1 gene, then 70% of these carriers are likely to develop breast cancer by the age of 80 years old. They are also associated with some other cancers. Half of the patients who are carriers unfortunately go on to develop ovarian cancer, and there's an increased risk of bowel and prostate cancer as well, obviously prostate being in men. And then we've got the BRCA2 gene, which is on a different chromosome, chromosome 13, around 60%, so it's less risk, but only by 10%. 60% of these carriers will go on to develop breast cancer by the age of 80. And then there's the 1 in 5 risk of developing ovarian cancer as well. So these are the 2 main genes to be aware of in terms of breast cancer. So just when you've got an alarming breast lump, so the lumps that we talked about for the cysts or the benign tumours, they had sort of very different features to alarming breast lumps. So those ones were mobile. Some of them were fluid filled, so they were fluctuant, whereas these ones are immobile. When you're doing your breast examination, the lump will not move. It feels like it's very fixed and tethered to the underlying structures. They often feel irregular, so the border doesn't feel like it's a very smooth, circular, round lump. It will feel irregular and lobulated. As I said, the border is quite poorly defined, and it can be quite difficult unless you're very well experienced to differentiate between the normal breast tissue and the lump, especially because the border is not very well defined. It's pain. They are painless. Sometimes they can have associated skin changes, and we'll go on to discuss that. You can have bloody discharge or clear discharge from the nipple, and then you've got the systemic symptoms of just feeling generally unwell, maybe weight loss, and things like that. In worst case scenarios, if the diagnosis has gone amiss for a long while, they might have symptoms relating to metastases to the sites that we've mentioned as well. So that's something to be aware of. Although in the UK, we're very good at picking up breast cancer early on and treating. So hopefully you won't encounter any or many patients who present very late with metastases and things like that. In terms of the NICE guidelines, so any unexplained breast lump in patients who are 30 or above, straight away a 2-week wait referral, or if there's unilateral nipple changes in anyone who's 50 or older. So with nipple changes, I mean the dimpling, the retraction, discharge, etc. So that's really important to be aware of. They'll be referred for 2-week wait referral to the breast clinic. You can then consider a 2-week wait referral for anyone who's got a breast lump, a lump in the axilla, and they are 30 years or above, or if they've got skin changes suggestive of breast cancer. So here you'd have to just use your clinical judgment and the history that you're taking with your examination to decide whether it can be a routine referral or if it should be a 2-week wait referral. And then a non-urgent referral would be anyone who's got an unexplained breast lump and they're below 30. So you'd still refer them to breast clinic, but it's less likely to be malignant, and so they'll be under a non-urgent referral rather than a 2-week wait, and that's the NICE guidelines. Okay, so I just want to see if you guys have any ideas about the breast screening program in the UK. I'm just going to put the poll up if you give me 1 second. So I'll just give you guys a couple of minutes to answer the question and then we can see. Okay, so most of you gone for the right answer, which is option number 1, and that's the timing and frequency being 50 to 70 years of age, and that's being every 3 years. I'll go on in the next couple of slides to talk about the screening furthermore, so I'll explain to those who chose the other options why number 1 was more the correct answer. And then we have another question coming up, so I'll put the poll up for that as well, and you can give you guys a couple of minutes for that. Okay, cool. So most of you have gone for option 4, and if you've gone for the others, option 4 is the right answer because I'll just quickly go through the scenario. She's 33 years old, so she's over 30. She has a lump in her right breast, so it's in the actual breast itself, not the axilla. It's painless and there's no other symptoms. There's no family history. It's 2 by 2 in terms of size. It is smooth, although painless, and there's no skin changes. But if we go back to our slide about when to refer, this would be an unexplained breast lump because there's nothing in the history that suggests what it could be. There's nothing about infection or any pointing towards any definitive diagnosis. So it's unexplained, and she's over 30, hence why she would need to be referred under a 2-week wait referral. Okay, as per the NICE guidelines. Okay, so as I said, we'd go through the breast screening program in the UK. As you all know, breast screening or screening for cancers, they help with early detection and so reduction in mortality, quicker treatments. In the UK, we offer screening mammography every 3 years to women who are 50 or 50 to 70 years old, because it's the average risk profile in the UK for women. But if anyone who's outside of this age range, then they can either self-refer or their GP can refer them if they've got any suspicions of breast lumps or any suspicions, and they can go and have their mammogram. So there are some women who have risk factors that would potentially put them at higher risk for breast cancer. So if they've got a strong family history, or the BRCA genes that we talked about, or some of these other genes that you can see on the slide, and if they have these risk factors, then they might use MRI in screening rather than using a mammogram. So it's really, really important to, if when you have your patient, when patients go for these screenings, or if you're in a GP, to get a good history from them and try and identify these risk factors, because it can sort of direct exactly how they'll be screened. Okay, as always, there can be false positives and negatives. So it's based, once patients go for screening, if there's any other concerns that they have after they've been screened and it's been negative, it's still really important to listen and try and refer them to the right place for further investigation if needs be. So then moving on to the types of breast cancer. So we've got invasive breast cancers. This kind of means that the cancer cells have penetrated past the basement membrane of the ducts or lobules, and they've spread into the surrounding breast tissue, but not to other organs. So when they say invasive breast cancer, that's what we're referring to. There's two major types. So we've got the invasive ductal carcinomas, which make up to 80% of the invasive breast cancers. And we've got the invasive lobular carcinomas, which make up about 5 to 10%. And they are very both different in terms of morphology and histology as well. So the invasive ductal carcinomas, which are the most common types, they're sort of irregular nests of tumor cells. They lack a distinct basement membrane, and they have associated gland formation with them. Whereas the lobular carcinomas, the cells sort of lack cohesion, and they can their morphology can have a signet ring appearance. So that's kind of how, on morphology and histology, those are the sort of features that they'd use to differentiate between them. But as I said, invasive ductal carcinomas are the most common invasive breast cancers. There's other types that I haven't put on the slide there, but you can have medullary carcinomas or metaplastic carcinoma, but they are very rare. So for exams, especially, I'd be very surprised if they came up or if they asked about those. Okay, so, and that's just sort of what they look like on histology. The signet cell breast carcinoma, that's what they look like. And then you've got the invasive ones as well. Invasive versus a lobular, invasive ductal versus lobular in A and B, showing their sort of morphology features that we spoke about in the previous slide. Okay, and then moving on from invasive breast carcinomas, we've got ductal carcinoma in situ. So these are cancerous epithelial cells of breast ducts, and they form about 20% of breast cancers. They're localized, and they are quite often picked up by mammograms. They do have the potential to spread locally over a good few years, and they can become invasive breast cancer. So that's very important to know when you have patients with DCIS, that they can become invasive breast cancers. But if they are picked up early and they're fully excised and they've got adjuvant treatment with hormones or chemo, radiotherapy, etc., then they've got pretty good prognosis. As you can see in the image, just sort of they grow in the actual ducts themselves. And then moving on to the lobular carcinoma in situ, they're again non-invasive lesion of the lobules, and they are also, they can be quite asymptomatic and sometimes go undetectable on a mammogram. They're usually incidentally diagnosed on breast biopsies. So that's something to be aware of when you have patients with family histories. Just because they don't have symptoms, they don't have a lump, doesn't mean that they are completely risk-free and that they don't have a lobular carcinoma in situ that's just not been picked up by screening. They also do pose an increased risk of invasive breast cancer in the future. So again, that's something to be aware of. In terms of management, this is obviously based on clinical judgment, and usually the breast consultants will decide. But if it is a low-grade carcinoma, then they can be chosen to go through surveillance and do examinations every 6 months and yearly mammograms, just to see if they don't need any treatment, that is, and see if it progresses and changes throughout time. But most of the time they'll probably be excised just because of the risk of invasive breast cancer in the future. And then going on to Paget's. So Paget's is a sign that there may be breast cancer in the tissue that's behind the nipple. It is possible to not have underlying cancer and have these changes around the nipple, but most of the time it is associated with breast cancer in the tissue behind the nipple. They can represent the ductal carcinomas in situ or invasive breast cancer. The images show what they look like, so it's really just about the skin overlying the nipple. It can sort of mimic eczema or dermatitis, where it looks quite angry, it looks quite dry, scaly rash around the areola and around the nipple. Patients can complain that they're itchy or painful, and they can sometimes have discharge or bleeding from the nipple. And then, as I said, because they are associated in a lot of the times with breast cancer behind the nipple, about 50% of patients can actually have a lump behind the nipple as well. So half the patients can just have the skin changes, or the other half can have a lump behind the nipple. So it's really important to be vigilant in these patients, gain a good history, and join your examination if there is a lump to pick it up. But if there is not a lump, then it doesn't mean that it's not as concerning. So that's something to be aware of, and that's what they look like. So going on to, once you see these patients, the triple assessment, it's essentially a one-stop clinic where the breast consultants will do a thorough history and examination, covering all the risk factors, any medications or anything in their history that could put them at risk of breast cancers, or if they're thinking of a benign condition, then obviously that could be it as well. And then they'll do examination. So it's really important to have a good look and compare. If there are unilateral symptoms, then make sure you're comparing with the side that is asymptomatic and is normal. There you're looking for any foreign body, any scars, any masses that are obvious to the eye. And when you're palpating, it's really important to be systematic. So rather than just going in and feeling around without actually, knowing where you're starting and where you're finishing, it's really important to start and have quadrants, start on the normal side so that you can have something to compare to. And if you do feel a lump, it's really important to understand if it's if it has poorly defined borders, if it's moving, if it's fluctuant, if it's feeling hard, etc., etc. And of course, don't forget to have a feel in the axilla just to see if there's any lumps or any changes in the lymph nodes there. And then they're often sent for either a mammogram, depending on their age. So if they're over 35, they will have a mammogram, and if they're under 35, then they'll have an ultrasound scan. And then they can take core biopsies, just to send off the samples to the lab and see definitively what the breast lump is made up of, and if there's anything concerning going on there. So it's really a one-stop shop. They'll go and have the history, imaging, and histology to let them know what it could be. So just a little bit more about the sort of different investigations that we have available for breast presentations, especially breast cancers. The patients can have lymph node assessments. So anyone who's diagnosed with breast cancer, they can have an ultrasound-guided biopsy of any abnormal nodes, especially if they have any concerning features in their axilla. Then we've got sentinel lymph node biopsy, which can be done during surgery if there's any suspicion that there's spread to the lymph node, to the sentinel lymph nodes, and they'll send off the sample and see if there's anything concerning there. And then we can also test samples for specific breast cancer receptors that can be used to guide chemotherapy, as you all know. So there's the estrogen receptors, ER, progesterone receptors, and the human epidermal growth factor, HER2. And we'll go on to sort of talk about chemotherapy and how they're used to guide, how the receptors are used to guide that. Okay. So we'll just have a quick SBA again, just to go over a few things. So I'll just release the poll to you guys and give you a couple minutes just to go through things. Okay, so most of you have gone for option number 2, which is the correct answer, and that's a mammogram. So if we go back to the screening slide, a mammogram is done if the patients are over 35 years old, and that's just because mammograms are a bit more useful in patients who are older and have denser breast tissue, and hence why anyone who's over 35, it's more appropriate to do a mammogram rather than doing an ultrasound scan. So this lady's age was really the biggest giveaway or clue for the right answer here. Okay, I'll just go back. There we go. So in terms of just quickly going over the management of breast cancers, there's a variety of things that we can use. You can use surgery to excise, there's therapy, there's radiotherapy, chemotherapy, hormonal treatments, or just even symptomatic relief. So we'll quickly go over those. So surgery, of course, involves the removal of the cancer tissue and just making sure that there's clear margins around where you've excised. That's very important. So you can have wide local excision, or in some cases, patients can have a full mastectomy, so removing the whole tissue, the whole breast itself. And sometimes they can go on to have breast reconstruction further down the line, or even on the same day, if the surgeons are happy to. During surgery, patients who have any sort of nodal involvement, they'll do removal of the axillary lymph nodes, and then they can send those off for testing and just to make sure if there's any issues. But of course, anyone who has axillary clearance, they will be at risk of having chronic lymphedema in their arms. So that's always important to counsel patients for before going for their surgery, because it can be quite bothersome and affect their quality of life. Chemotherapy is often guided by the oncologists, so there's a variety of different things, but they essentially can either be used to shrink the tumour before they have surgery so that it's easier during surgery to remove, or if you're worried about the risk of recurrence after surgery, then you can use it in an adjuvant way where you're using it to reduce the possibility of recurrence, or if patients have metastases or recurrent breast cancers, then we can use chemotherapy in those instances too. Radiotherapy is another option. Again, it's used often to reduce the risk of recurrence, but radiotherapy does have a lot of side effects, so they can impact patients quite a lot when they do have them. So it's very important to counsel them and just make sure that they are mentally ready and prepared for those side effects as well. And I've just noted them there. And then moving on to hormonal treatment. So these are sort of targeted at those receptors that I mentioned earlier. We've got tamoxifen. The hormone treatments are for the estrogen receptor positive breast cancers. And we've got tamoxifen, which is a selective estrogen receptor modulator, or SERM. It's usually used in premenopausal women, and it works by blocking the estrogen receptors in breast tissue while simultaneously stimulating the estrogen receptors in the uterus and the bones. So that's how they work. But so although they help to prevent osteoporosis, they do increase the risk of endometrial carcinomas. So it's important to be aware of those when you're, and especially when you're counselling patients, or if you have patients who are at risk of endometrial cancers, then tamoxifen might not be the best option to go with. But obviously, all these treatments are directed by specialists, so they'll know a lot more about them. And then we have aromatase inhibitors like letrozole or anastrozole, and they're used in postmenopausal women. Essentially, aromatase is an enzyme that converts androgens to estrogens in the adipose tissue, and breast tissue has a lot of adipose tissue. So after menopause in women, aromatase is the primary source of estrogen, hence blocking these enzymes essentially blocks the creation of estrogen in the adipose tissue. So that's why we use those. And then we've got the targeted therapy with monoclonal antibodies like Herceptin, or the others that are monoclonal antibodies targeting the HER2 receptors. Herceptin is the common one, and then the other two can be used in combination with Herceptin or on their own. But again, these are all treatments that are directed by specialists. Okay, and then just a couple SBAs to finish off. So I will just release the poll to you guys. Okay, just give you a couple minutes. So we haven't gone over this, maybe, or breast cancers in men, but just using this question to highlight a key point as well. Okay, so most of the people who answered the question have chosen number 2, which is the correct option. So I'll just quickly go over the key words in the question. So this is, unlike the other questions, this is a male patient presenting, and they're over 60. They have a 2-week history of bleeding from the right nipple, and it's just gone over some medical history there. And on your examination, you notice some oozing of blood from the nipple with a fixed mass under the right areola. So here it's just the patient, the question is asking sort of what's the most accurate in male breast cancers. And I just wanted to highlight that even though breast cancer is rare in men and has a 1% risk, in men with Klinefelter, it's actually a much higher risk and approximately 1 in 25 chance in individuals with Klinefelter syndrome. So again, as I said earlier, it's very important to take a good history, and just because they are male doesn't mean that they don't have a risk of developing breast cancer, and Klinefelter is one of those that really increases their risk. So that's very important to be aware of. And just some other risk factors for male breast cancer that I wanted to highlight was age, just like with other a lot of different cancers. If they've had therapy, radiotherapy, if they have a family history, those are quite big risk factors in men as well. So I just wanted to use that question to highlight the importance of not overlooking breast cancer in men. And then the final question, I'll just quickly release the poll. Okay, so all of you have gone for the right answer, which is mastectomy or wide local excision. This question's kind of straightforward in the sense that it indicates the diagnosis being DCIS. And as we talked about before, DCIS has got a risk of transforming into invasive breast cancer. And this lady's still relatively young. There's no contraindications mentioned about going to theatre and having surgery. So the most appropriate option here would be to have surgical removal through a mastectomy or a wide local excision. And it's possible to have adjuvant chemotherapy, but the most appropriate answer here is mastectomy or wide local excision for her. And there's no mention of anything about hormonal signs or things like that. So that's why that's the most appropriate option. And then just finally, for anyone who's interested in breast surgery, usually just a quick summary of it really is you complete F1 and F2 just like you would for any other speciality, and then once you've done that, you can apply do core surgical training, and then the two routes that you can go through are you can do general surgery and then specialize in breast surgery, or you can go into plastic surgery training after core surgical training and then specialize in breast surgery after that as well. So those are the kind of routes to go into. But if anyone has any questions about that, feel free to message me. I don't mind. I'll put my email in there about anything in the slides, or if you're interested in breast surgery and you want to know more, I'm more than happy to talk about it. If anyone has any questions, please let me know. Otherwise, I'm just going to quickly grab, just find the link for feedback. If you guys could please complete that before you shoot off. Thank you all for coming. So that's my email in the chat if anyone wants to contact me with any questions or anything. I'm more than happy to help. Thank you, guys. But yeah, please fill out the feedback form so we can continue doing these. I'll just hang around for a couple of minutes, but once you've done the feedback, you're free to go. Thank you once again for coming. Someone just asked if it's younger men or older men that are at increased risk of breast cancer, and it's older men. Sorry if I was a bit quiet or didn't mention that clearly enough. It's older men. Thank you, guys. I'm just going to end it here. Thank you once again for coming.